My name is Jimmy Turner. I'm a Regional Anesthesia and Acute Pain Medicine Fellow here at Wake Forest. I'll be staying on faculty next year, and I'm going to talk to you about an abstract I'm presenting at ASRA, the national meeting this year, on Decadron and whether it prolongs peripheral nerve blocks or not. For a little background, the goals in regional anesthesia are obviously to provide sensory blockade to help with analgesia while avoiding the motor blockade you might have with a peripheral nerve block. This can be accomplished through a few different modalities. One is choosing an appropriate block, for instance, using an adductor canal block instead of a femoral block. You might also choose certain adjuvants to accomplish that goal. However, there are many adjuvants, so this begs the question of which adjuvants should we use. Decadron is a glucocorticoid with minimal mineralocorticoid activity, and it has been used in multimodal analgesia in doses greater than 0.1 milligrams per kilogram to help with pain relief. And it's also been studied in regional anesthesia to determine if Decadron prolongs peripheral nerve blocks through an intravenous route or perineural route. So there are multiple definitions in how peripheral nerve block duration might be defined, and many studies have looked at surrogate outcomes or endpoints in order to define this, such as time to first analgesic request or opioid consumption, or simply asking the patient when they thought the block wore off. However, we thought there might be a better way to define block duration by directly measuring it, and so we sought to look into that. But before we get to that, let's talk about some reasons why people might use surrogates. They are often easier to study. It's easier to study to conduct using endpoints that are surrogates, such as opioid consumption, instead of checking serial neurologic exams in patients. This allows for the exam and the study to likely be completed. And some people might argue that neurologic serial checks aren't endpoints that would be clinically helpful. And some people would argue that clinically helpful endpoints would be opioid consumption and time to first analgesic request. However, this does not actually answer the direct question of how long a peripheral nerve block might last. We set out to answer this question by having 115 patients enrolled in a randomized placebo-controlled trial here at Wake Forest. These patients received a psoas compartment block for total hip arthroplasty, and each of them received 25 cc's of 0.25% bupivacaine with 1 to 200,000 epinephrine. They were then broken up into 3 groups. 15 people received placebo following the block or normal saline, 50 received 4 milligrams of Decadron, and 50 received 8 milligrams of Decadron. And then they underwent serial neurologic exams with pinprick using a 25-gauge Whitaker needle in order to determine how long the block lasted. This was performed in addition to the secondary outcomes, which included the surrogate outcomes other studies included, such as opioid consumption and time to first analgesic request. As you can see from the results, these durations were all about 19 hours with a standard deviation of about 6 or 7 hours. They were proven to be clinically and statistically equivalent, and our assumption was that the 4 milligram and 8 milligram groups would provide a significant duration longer than the placebo group, and that they would also be the same. We found that the 4 milligram and the 8 milligram group were the same. However, neither of them actually prolonged the nerve block any longer than the placebo group, suggesting that they were clinically and statistically non-inferior or equivalent. In addition to that, we looked for superiority from the 4 milligram and 8 milligram groups compared to placebo, because that was our hypothesis, and obviously we found none, with t-tests suggesting that they were non-superior compared to placebo. We also looked at opioid consumption and time to first analgesic requests, the surrogate outcomes that were done in other studies, and determined that they corroborated the other findings in decreasing opioid consumption and taking a longer time to first analgesic request in the higher 8 milligram Decadron group when compared to placebo. However, when 4 milligrams was compared to placebo or 8 milligrams was compared to placebo, neither of these produced a statistically significant difference, suggesting that there is a weight-based dose that we already knew of, 0.1 milligrams per kilo, that would provide a decrease in opioid consumption and increased time to first analgesic request. So what we learned from this is that it's important to include placebos in these studies, and that we haven't necessarily found the answer yet when using surrogate outcomes, and that surrogate outcomes or endpoints are often not helpful because they don't actually define or answer the question we're looking for. Therefore, we suggest that systemic Decadron does not prolong a psoas compartment block, although whether it prolongs other peripheral nerve blocks is to be determined, though we think that these conclusions could be drawn out potentially to other peripheral nerve blocks. In addition to this, we did determine that though Decadron doesn't prolong a peripheral nerve block in the psoas compartment block, it might be helpful in a multimodal analgesic approach, as previously stated in other studies.